I'm the Managing Director of the Waterloo Institute for Health Informatics Research. This is a seminar, a part of our research seminar series, and I welcome Claudette DeLenardo here today from Grand River Hospital. She'll be speaking on developing a patient portal, adopting lessons learned for future development. So I'm really excited about this seminar, and I've heard Claudette speak before. She's a very dynamic speaker, and I'm sure you will enjoy her presentation. Before we begin and introduce our speaker, I'd like to make you aware of two seminars happening now in our next year, January 2008. On Wednesday, January the 16th, we'll launch our new Smarter Health Seminar Series. We'll be looking at new facets and faces of health informatics, and our first speaker will be Dr. David Hill from London Health Sciences Centre. David will be speaking on critical support for clinical research and the role that health informatics plays in that. So I'm looking forward to that seminar. And this seminar series resumes on Friday, January the 18th. And our guest speaker will be Dr. Ann Pittock from the School of Computer Science here at the University of Waterloo. She'll be speaking on electronic social networks and dementia prevention. So I hope you all have a good holiday season, but come right back and visit us again in our seminar series in January. So without any further ado, Maher, will you introduce our speaker?
Good afternoon, everyone. It is my pleasure to introduce our guest speaker today, Claudette DeLenardo. Claudette is the Director of eHealth Technologies at the Grand River Hospital in Kitchener. She is a registered nurse with a Master of Science in Nursing from the University of Phoenix. She has been working in the healthcare industry for acute and non-acute settings and has been involved in the development and application of patient portal technologies. Claudette is the recipient of 2004 Healthcare Informatics Information Technology Innovator Award and 2007 Cancer Quality Council of Ontario Individual Innovation Award. Today, Claudette will talk about the development of a patient portal and the lessons learned for future development. Welcome, Claudette.
Good afternoon. So I'm going to premise this discussion by saying I'm not a geek, when I first started this project, I couldn't even open an Access database. How sad is that? And secondly, I'm not a researcher, but I am a nurse with a lot of passion about patients and patient-centered care and providing patients with an experience in which they can modify their behaviors and be engaged in their health care in order to achieve really good outcomes. So, we're not advancing. I am pressing down, I'm pressing enter, it's not happening. Page down. There we go. What did you press? Down here?
That one.
I did press that one. Oh, well, okay. See, I told you I'm not a geek. So in the beginning was really the year 2004. I was asked to participate on a one-week assignment, which now it's still, look at that, isn't that bizarre?
It's catching up.
It's catching up. Holy smokes, let's go back. I'll just talk. So we decided at Grand River Hospital what we wanted to do was engage patients in the care that they were receiving. And we really didn't know how we were going to do that. And it was actually a line item in one of our strategic plans, or in fact our first IT strategic plan, engaging the patient. Had no clue how we were going to do that. I was fortunate enough to be asked to participate on a week-long project in which we were developing two IT applications. One was a patient-centric, what we call the patient-centric application, which has since become my care source, a patient portal or a personal health record. And the other one was decision support. And so at the time I was the director for the children's program, and my real interest was in decision support because I wanted to get all the money I could from my program so I could provide care. But actually became quite engaged in the patient portal aspect and trying to engage patients in care. And so what we decided at the time was our CIO was a pretty energetic fellow, Mr. Kearns, and he and I had some philosophical differences in terms of what the patient portal was. And so for me, the patient portal was a personal health record, a space where patients could get information about their health care from the electronic health record or health care system, information systems, and could potentially down the road submit information into that electronic environment. And for him, he felt that everything in the personal health record belonged in the EHR. So I was thinking, well, my thing with him was, well, you know, if I'm journaling in a diary, I don't necessarily want that to go into the PHR or the EHR because I might be complaining about you as a healthcare provider, and that's a very personal perspective. And so he's gone, so now we're calling it a PHR. Yes?
PHR is?
Personal health record. And I'll refer to that because Dawn and I have had some conversations about PHR, EMR, EHR, what do we call things? So in my world, PHR is personal health record. So I talked a little bit about the vision and about the idea coming together, and the idea of actually developing this type of application came primarily through our cancer services. Cancer is considered a chronic disease now. In the past, it was considered an acute disease, but because of survivorship rates, now is considered chronic. And at the time, we were developing our new cancer center, which was high-tech, high-touch, and we felt this was a really good fit. And we also wanted to have a very practical approach to what we were doing. So looking at clinical processes and what we could do to facilitate communication with patients. Lastly, because healthcare doesn't have tons of money, she doesn't have any money, really needed to engage in the development of an application in which we could maximize our resources in terms of what we were spending. So looking at ways that we could integrate our health information systems to provide a seamless view for the patient. Well, at the time, I'm going to talk a little bit in the context of cancer because so much of portal development in our world has been about culture and about change management and looking at different programs and services that we provide to different patients who have different diagnoses. You'll notice that I don't call patients cancer patients because you're a person first and you have a disease or a health condition secondly. And that's really the message that we'd like to facilitate across our healthcare system. So in the beginning, we had some assumptions about what was happening in cancer. And really looking at the dissemination of information, the provision of supportive care, and the delivery of services. And we knew, quite frankly, that there were issues related to that. In a CCS, Canadian Cancer Society study in 2000 that was published later in 2003 and came out, those things were validated to us. So what intuitively we thought was happening was actually happening. And that particular study indicated that information and communication needs rank really high with patients. Obviously, they want to know what's going on and they want to get the best care. That there were extreme barriers to obtaining valid information. And certainly, if you Google breast cancer on the net, you can get 3 million hits. And so what's really important and what's really valid for your particular case. That there are communication issues with healthcare providers, imagine that. And that the delivery of information is fragmented, not only in the acute care setting, but through the continuum of care and with home care. What we didn't know, we had absolutely no idea at the time if patients had access to computers in the home. We didn't even know. We didn't know if they would use technology to supplement their care. And if they did, if they used such an application, what would they use it for? Staff. What would staff think about this? And I can remember, quite frankly, meeting with a bunch of healthcare providers, and I won't tell you their designation. They said, no way, we're not doing this. And my response was, well, we've signed a contract, we kind of have to go ahead. So I said it with a smile, and I laughed. But really looking at staff and looking at the culture to see, would they really see this as just another IT project? We had a fair amount of change organizationally in terms of IT. And so this was just another thing coming along, and would it be seen that way? Would it add on to their workload? Frequently when you speak with healthcare providers, like, I can't do another thing. I just can't fit another thing into my day. And so really trying to frame the development of this application such that the message would be, we're going to assist you with your with your workload and to help you streamline that and improve communication with the patient. And lastly, was it just going to be another thing for them to do? What we thought patients wanted, more and more information, wasn't necessarily true. They didn't want more and more information. They just wanted valid information, consistent information. I had the experience as I was building the portal to attend a nurse-led clinic and really wanted to check out what we were doing with patients in terms of explaining conditions, in terms of providing information. And so I sat quietly in a number of consultations and watched patients, both nonverbal and verbal communication with their healthcare providers and a nurse. And so the scenario is, you know, I'm talking to you and I'm mentally, as a healthcare provider, checking off everything that I need to tell you. I'm drawing you pictures, I'm checking it off. And after the fact, after that interview was done, each and every single patient that I spoke to, my question was, what was the most important thing that you needed to remember from this interview? And the key message was, you're going to have to take your temperature. That was the key message that I could decipher. And they said, I don't know. I would say, where's your coupon for your thermometer? I don't know where I put it. And so really looking at the experience of patients and how we approach patient education opened new eyes for me in terms of workflow processes within our organization. So it's not necessarily they want more and more information. They want information that is timely and pertinent to them, in which they can process, and to provide a backup to be able to provide that consistency and reinforcement of that particular information such that they could have knowledge transfer. Information in the absence of explanation. So with the first iteration for cancer, we really provided, you know, here you go, we have this great portal, we've got all this information for you, go out and use it. Okay. So we have patients, we have almost 1,000 patients who have signed on since 2004. That's not bad. And they go out and they use it, but are they really looking at the information? They do so in the beginning because cancer treatment is very prescriptive, and so we want that ongoing. So we missed the whole motivational piece at the beginning, and we also missed at the beginning the fact that we needed to embed the portal in terms of workflow processes. So when the patient comes in with the clinician, they're doing things together, and so we're still working on that in the cancer world, and I'll show you how that's different in the chronic kidney disease world. Use of technology to use self-service modalities. Well, we had this great business case in the beginning. We thought everybody's going to order their meds online. Well, guess what? They didn't. They just didn't do it. We have some patients that do it, and those are the patients that I would say are the ones that are the consistent users. So they're in there. They're looking at the information. They're also self-monitoring their disease, so they're writing in, you know, when they have watery eyes, they're tracking their temperature, they're ordering medications, they've filled out a health profile. But not every patient is ordering meds, and so that was a little bit of a shock to some people, that people wouldn't just automatically do that. Easier access to healthcare professionals. Patients want this. There's no doubt in our mind. Every survey we've done since we've implemented Patient Portal, they want secure electronic communication. What's the problem? Why can't we do it? Right? No, it's going to increase our workload. As a physician, increase the workload. We don't get remunerated for that. Why would we do it? Those are huge barriers, and barriers that we can't help to facilitate at this point, because we're not going to change that model overnight. Access to information contained in the health record. They want their discharge summary. They want their lab results. They want their medical imaging results. They want their images. And so what's the barrier? There's a barrier for that. Oh no, they can't have that information. So what's the response? It's their information. Oh no. You know what? If someone gets a really bad result, they're going to go and kill themselves. If they're not going to understand that. Well, is that absolutely true? There's not a lot of research literature to support this. There are some organizations, particularly in the U.S., where they release lab results. Sunnybrook is now releasing results in real time. There's no vetting of those results. And so there have been no adverse events. And so really, when you talk to patients, what do they say to you? I'd like those results in my own home where I can process the information. not where someone's telling me. I don't want someone to tell me on the phone, but some of them say they want it online. They want it provided to them online in context, so they want a message about that. So that's been an interesting process, and we're working through with our renal program. We're using the Ambassador problem-solving approach to looking at workflow processes and how we could facilitate the release of health information, particularly those I've mentioned in terms of results and images and that kind of thing, in the electronic environment. Because FYI, we're already doing it. It's just, we're already doing it. We're already telling patients what the results are. And they need those results in order to recognize that whatever behavior change that they've managed to do to achieve a goal is working or not working. So it's a very important piece of the pie. And we really thought that patients would track their effects of their disease, particularly with cancer. Not all patients are doing this in our environment, but there are patients that are looking at key things. So we kind of monitor that and change the environment to reflect that utilization. Assumptions. Oh, it's bad when you have assumptions when you're doing a project, isn't it? It's just a killer. So I thought, I'm not very bright, that those workflow processes were already predefined. We're healthcare. We should know what we're doing. Guess what? We don't all the time. That patient education was an inherent component of care. Not necessarily so. Making a big assumption about the competencies of different healthcare providers in terms of the ability to utilize adult teaching principles, and recognizing that as we work through this first iteration, that there are gaps in those competencies and we need to do a much better job of educating our staff. That we had competencies existed to support knowledge transfer, not necessarily so. And I think the big light bulb for me should have been looking at actual clinical practice. And clinical practice and changes in clinical practice are difficult because there is so much change in the healthcare environment. But it's, looking at certain practices and getting staff to change their behavior in terms of what they're doing, but then sustaining that change, and that's a challenge we face. That information that existed could be easily replicated. So here's my story about that. I went, and everybody said, treatment. Treatment. Here we go. So we have all that information, right? We do? That's fabulous. So I go up and I talk to the supportive care nurses, and I say, okay, give me what you got. What do you mean? Give me what you got. How do you describe a treatment protocol to a patient? I mean, it's complicated, right? They've got words like myelosuppression and neutropenia and da-da-da-da-da. So what they gave me was a photocopy out of a textbook. I said, you got to be kidding me. How do you explain that? No, we give them the photocopy, and if they have questions, they ask us about that. I said, well, how do they even understand that? How do they understand the words? Listen, I don't even understand some of these words. I had to go one time to an oncologist and say, okay, here's this word, and here's this side effect, these two side effects. Are they the same? Are they different? Because I can't figure it out. I've been on the internet, and I can't figure it out. And he looks at me, and he says, I know you've been on the internet. And so he was going on the internet to figure it out. So if you can't figure it out and I can't figure it out, how are you going to figure it out? We can't figure it out. So big assumption about the ability to take information and translate it. And that's exactly what we had to do in the beginning, was take that information and reading some of the information, big bold letters on a pamphlet, do not. It's like thou shalt not, right? There's God coming down, and you shall not touch your line that you've got inserted in your chest. Don't be touching that, and don't be doing X, Y, and Z. And so really looking at competencies in terms of health literature, in terms of learning style, in terms of readability, in terms of appropriateness, and having to translate that into a web environment was a challenge. And so certainly at Grand River, none of us were experts at developing patient education. And I would say we're still novices, because it's a real skill to be able to do that and to bring that language down to grade 6, especially when you're dealing with diseases like chronic kidney disease or cancer, where they're using those big words. And so believe it or not, one session we had stomatitis, mucositis, mouth to bottom soreness. It took 8 people and 1 hour to come up with that. It's not an easy thing to do. And it's not an easy thing to get clinicians to think about changing the language they use when they speak with patients. because people came back after and said, you know, we've been through this whole development. We used a big multidisciplinary team. We had a patient on the team. And they said, you know, from this development, I've changed the way I speak with patients. I've changed my language to make things much simpler. And so that was a bonus that came out of this project, something we hadn't anticipated. We could abstract data from the health information system to support our business case. Holy heck, we couldn't do that. Not only did we not have processes defined, we couldn't get the information out. And so one of the things was, we're going to give everybody their appointments online. This is going to be great. Access 24/7. We're going to connect to our scheduling system. How many patients, was the question, cancel their appointment? Can't tell you that. What do you mean you can't tell me that? Because we don't keep track of that. What do you mean we don't keep track of that? We just don't. So you've got a business case that you've brought to your board, and then you go back and you say, well, I can't demonstrate that we've improved that business practice because we had no pre-data in the first place. So in healthcare, never assume that we have that information, because we don't necessarily do. Understanding of roles and responsibilities of team members. So we work with a lot of different people, and we don't always understand what each other's roles and responsibilities are. And sometimes we get the real mix. And we go back to the previous slide about communication needs. Guess what? That's where the conflict comes, because what one person is telling you is not necessarily the same as another person. And so really one of the benefits of doing the patient portal was bringing those team members together and actually having the knowledge sharing and the dissemination of information across those different roles and responsibilities. And we also assumed that technology was going to be seen as a positive. And sometimes it is, and sometimes it's not. When it works, it is, but when it doesn't, it's not. Challenges with technological development. Well, for me, I'll put in my comment, is just even understanding it. Okay, so I talk about patients and healthcare providers having a language. This is a totally different language. And so really trying to understand that development and understanding how to take an off-the-shelf application as a base product and shape that into something that you want to be, like I call it sexy. Like, let's make this great. Let's make, you know, because you want to engage the user, right? Let's make this worthwhile and engaging for the patient and get them to keep coming back. And so, you know, I had a hard time hearing, I wanted a wave on something. No, can't do that. What do you mean can't do that? Can't do that. I wanted, you know, let's make this layered. Can't do that. What do you mean can't do that? You know, that's really frustrating. So if you're starting from scratch, I think you have more of an opportunity to do something the way you want it to do, but really understanding. And Grand River was highly criticized by some of our colleagues in terms of, well, you didn't do this, and you didn't do that, and you didn't do this. Yeah, we know. We know we didn't do this, that, and the other because we were constrained, not only by the application itself, but the resources, the fiscal resources in order to do that, and the project. So I'll talk a little bit about project management at the end. Fitting healthcare practices into an IT application, difficult thing to do because I'll go back to workflow processes aren't predefined, right? And you can't necessarily get the information out of the health information system. So those are things that we found were challenging. The word depends. I really didn't like that word, but I've grown to love the word. That depends. Every scenario you come to, you know, what would happen if you do X, Y, and Z? That depends. Okay, I'm having a hard time with that depends. Or working with different providers who manage, for example, one type of disease. I'll use hematology because I always like using hematology. So you have 5 hematologists in a room, theoretically, and guess what? We all have evidence-based practice guidelines that we're supposed to use. But it doesn't really happen because they all have little personal things that they're doing. And so you're having to develop a treatment protocol where you're explaining weeks and cycles of therapy to the patient, but bend it so you can meet the needs of all those 5 providers. So that's not an easy thing to do. That was a bit of a challenge. Working with developers is difficult, right? The language, as I said, I couldn't even open an Access database. And not only did I had a problem with them, they had a problem with me because they didn't know what I was talking about. I used to get emails back, I have no idea what you're saying, right? I was like, okay, I don't feel so bad now. And always asking why. You know, it's, no, can't do it that way. Get something back, no, can't do it that way. Doesn't work that way in healthcare. People aren't like that. It's not black and white. There's a lot of gray. Clinician engagement. Well, we were really fortunate. We had clinicians who were very excited about developing this type of application in our environment. And so we really maximized the use of multidisciplinary teams. Physicians jumped on board. We had patient representatives. And part of the jewels of working with a multidisciplinary team is the fact that I knew all of them. That was very good. But secondly was the fact that I could speak their language and that I can identify with each of their issues. Part of the challenging piece was challenging clinical practice. So an example would be, so we have a patient coming in, and the patient is getting an IV every single day. And so are you meaning to tell me that we're poking that person every single day? Yeah. Do you think that's right? That's what we do. Is it right? Is it the best evidence? And so there was a little back and forth about that in terms of, you know what, you could get a little defensive if you're a clinician, but it's really trying to promote what's the best practice that we can implement and how can we translate that in the portal environment to support the patient in understanding about their condition. Divergent thinking between practitioners, and I'll go back to that roles and responsibilities piece. A lot of divergent thinking, but trying to bring that together. And so recently we're working with a group of folks in our pre-dialysis clinic. And it was shocking to me that as I sat back as an observer, that the people that work in the pre-dialysis clinic really don't know the people that work in the area where we give hemodialysis. And I'm thinking, holy smokes, like this is one program, right? The renal program. But each stage doesn't know what the next stage is doing. So this is a way to bring things in the environment together. And I have to say that with the renal program in itself, a lot of energy and excitement, a different culture to work with than we had with cancer. Divergent thinking between practitioners and patients. Oh yeah. You know, the clinicians, dietitian. This is what the patient shall do, right? X, Y, and Z. And then you go and you take your wireframes and you go ask the patient, I'm not doing that. There's no way I'm doing that, right? And so you have to change what you're thinking about and really come back to the clinician to say, you know what? They're not going to do that. So why are you trying to force them? They're not going to change that behavior. And locus of control. Talked a little bit about the results piece in terms of locus of control. We can't give them those results, but they belong to the patient. Interesting enough, during a workflow process exercise, I had one of the nurses say to me, oh, it's me, I need to be in control, right? Healthcare practitioners feel like they need to be in control. So it's a big mind shift to say, you know what, it's about the patient, and the patient needs to be able to ask the questions and take ownership of managing their disease. Our early development in cancer focused on some very basic things that we've brought forward. We offered treatment plans for breast cancer in particular. We had 17. We have about 180 or something now for 20 disease sites, and we've learned a lot. And so those treatment plans and the preceding treatment plans that were developed are never static. There's always different iterations in terms of content, in terms of language. Educational content, appointment information. We went from a very ugly, here's the list of your appointments, to a calendar module where patients can download things into their Outlook and their BlackBerry. So that's progression in terms of what we've been able to do. The ability to track side effects, just a care teams member directory, and the biggest challenge is, can you email those care team members? No, not yet, can't do it. We're not there yet in terms of culture. Personal health profile, medication supplies, I talked a little about, web links, and a discussion board. So here's an example of the first edition. So this is my geeky friend, Kevin. He sent this to me, right? I said, this is what we want. And really that calendar piece, oh my God, I had to, I was persistent. I could be tenacious, like bad snot, right? I want a calendar. You couldn't figure it out. Why do you want a calendar? Well, people have to have orientation to time. You know, you're telling me that I'm going to have treatment for 20 weeks. Well, I'm counting. Can I go away at Christmas time? I don't know. And the proof in the pudding for me was we were talking about, cycles. And everybody around the table, all 8 people, they all had bags with them. They all pulled out their little, things you get from Hallmark, the little calendars, and they were counting weeks. So I thought, well, if we're counting weeks, you sure as heck think the patient's counting weeks. So that was our first iteration. Then we went to something a little different. So this is really the evolution of what we were doing. And so we've had a couple of upgrades since then, but really providing links to information. And I think in the cancer world, the important piece is you can be getting 5 different medications. Like, they're horrible medications. And so if you went and logically put all the side effects of all those information, all those medications on a list, they could be like this big, right? It's like, holy moly, why would you even take those medications in the first place? So what we did was looked at that list. We consolidated that list. We changed the language in terms of those particular side effects, and we vetted that through our clinician group, particularly our physicians, to come up with one little list that is more manageable. And then we provide some information in terms of, if you're having this for X amount of time, you need to call us. So it's some prevention. We don't want patients to end up in the emergency department because, they can wait there. And then we partnered with external organizations in order to provide evidence and information to support the patient experience. Here's a first iteration of our community resources. So basically, you'll see on the bottom, breast cancer, and it's kind of ugly and it's kind of boring. And so I said to my staff, okay, I want it a little bit sexier. And so you'll notice that we changed the community resources from a LIN perspective. Here's a LIN map. You click on that. Here's some information about cancer. Here's some information about renal. And then guess what? We've got it on there. We had it on there the first day, putting that on. So providing the information to the patient in the most appropriate fashion. In terms of cancer, we did do some research. We did surveys and we did a qualitative study looking at participants in terms of what they got out of the portal. And so looking at readability, and I have to flip to my stats because I don't know these off my head. Because when you're doing something like this in the very beginning, you're not always sure that you're getting to the needs of the end user. So looking at readability, out of the participants who participated in the study, I think there were about 200 patients, 83% said that the information was readable. So for development purposes, that was very positive for us because we were novices at changing information. 59% of the patients felt that their needs were totally met, and 24%, were getting there, are partially met. Only 3% said their needs weren't met at all. 81% said they would recommend the portal usage to others in their situation, and similarly that they were satisfied with it. And 54% said that they were helpful and they would use it again in their illness. 54% said they would that it was helpful in dealing with their illness. Participants also said that they felt they were more in control of their illness. They felt more hopeful, that they were better able to understand their illness. They were more comfortable communicating with their healthcare team, and it decreased anxiety. And so really as an application that we just really didn't know what we were doing, we felt that we were meeting the needs of those end users and seeing outcomes that we hadn't anticipated originally. In terms of staff and using the portal, one of the things I talked about at the very beginning was the fact that we had to go out and look at staff. Would they see this as just another thing to do? They're bored, they're not really engaged. But we looked at and did a small staff survey where we had about 32 participants respond, and 69% of those were nurses, and 68% that they had some level of familiarity. Now, knowing what the healthcare environment is like, there's a significant amount of turnover in the cancer program itself, so not bad. We could do so much better. 77% said they used that portal, and that was kind of a shock to us because we didn't think it would be that high. Almost 89% said that they promoted it verbally, and 28% gave them what we call a buck slip. So it's a little paper about what's on it. And 83% recommended use of it. So that was good. The limitations that nurses cited in using the application was time, training, and information. So not surprising to us at all. So we have a little bit of work to do there. In 2006 now, we were able to work with University Health Network and LIN4 to put a proposal together to Canada Health Infoway to develop our portal environment for chronic kidney disease. And we were successful in obtaining an investment from them in order to do that. And what we wanted to do was leverage our portal experiences, content and technology platform to cost effectively build and deploy this new iteration. So it's not really a new patient portal, it's an iteration of the portal platform. We have been successful in commonly developing technical specifications, functionality, and content, and that's been quite an adventure in terms of the fact that we're working with a community organization and a tertiary organization, two different cultures, extremely different workflows, and resources. Like, they got resources like you wouldn't believe. It's just me and 0.5 of me and one other person that's really working on this at Grand River. Develop an evaluation management framework, and we've been working with Shirley and Dominic and Dr. Gina Brown at McMaster to do that. And looking at high quality replication and implementation to support usability testing. That's a big lesson learned for us in this iteration. Completing a privacy impact assessment, and oh God, those are complicated. Ours is about 95 pages long. And then looking at relevant and comprehensive implementation tools, which Dr. Gina Brown has been absolutely essential in helping us to develop. And really to gain an understanding of the role and value of patient portals as an element of Canada's EHR strategy. So for Grand River, we'll be the first organization, I think, in Canada to actually facilitate the implementation of patient self-report data into an EHR, and so that will be coming in March of 2008. Changing clinical practice, a paradigm shift. So this is what someone actually said to me. Why don't the patients just do what I tell them to do? So I had to bite my tongue, and I think I had some seizure activity, and I had nasal flaring, so my nose was do this. But I kept it together. So the difference we've done with CKD is the fact that instead of saying, hey, we've got this patient portal, go out there and use it, we've actually integrated this into clinical practice. And really the basic premise is that this application will be used as an adjunct to the therapeutic relationship. So there's a give and a give. The patient and the provider working together to set goals to manage care. We've had significant clinician involvement in all the components of development and implementation. We do have divergent and convergent thinking, but that's okay. But they've been phenomenal in engaging and taking ownership of the content and the application so that they could use it in clinical practice. Shifting workflows and processes, I talked a little bit about already, particularly in things that really have the big punch, so lab results delivery, just even getting patients hooked up, subscribed to the portal environment, and changing that type of information in terms of orientation programs, marketing materials. We've had a huge change in how we've done that with CKD in that it's much more of an engagement. We've also at this point embedded one of the individuals on the portal team as a key liaison with that particular, with those particular clinicians. So instead of me going as the director, I've said, no, that's your role. You go and you make the relationships with the clinicians, because that's what it's all about. It's about relationships and how you can assist those individuals to improve their practice, but also to communicate different practices in relation to the patient. And the last thing was really thinking about thinking beyond the here and now. So, okay, yeah, I know this is what we do today, but what about the future? What do you think we can do in the future? And so starting to perpetuate some thinking about, how could we use this in the future in terms of a patient, for example, who is doing home dialysis, which is very common, and how could that patient document in their home environment, and how can we translate that using the portal? How can we translate that to the EHR? And so that takes a lot of thinking and thinking outside of the box. I normally hate that term, but thinking about how we could change our practices and the service that we provide to be much more patient-centric and much more effective. Really focused this time on a user-centered design approach. And so Dominic and I have had this little back and forth about the user-centered design approach. But we really didn't know in the beginning what patients were going to use with this particular application, similar to cancer. So we've had patients work with us on the multidisciplinary working groups in terms of content. What's important to you? Asking them. It's always asking them back, is this valuable? Developing that, challenging that, and showing that to them. Especially with the calendar and the action plans. So we developed these 2 action plans which have a motivational inquiry approach and provide the ability to track different physiological parameters or what you've eaten, and then we give them some feedback in terms of what their goals are, and then provide educational content. We've had end user surveys. So originally, you develop a proposal, you have all these ideas, and I think in the future when we develop a proposal, we're actually going to ask patients first about what they think is important to them to put in that particular proposal. But we had something called an ESAS tool, which is a patient self-report tool that's used in palliative cancer therapy. And patients said to us, yeah, we'll do it on the portal, but we won't do it on the telephone. We won't use the telephone. So we had to change that. We had a lot of focus groups exploring experiences and communication plan. We've had patient stories as well. Single most important thing, and something that we're trying to share with other individuals in the organization, is the importance of usability testing. I can't stress how important that is in order to get the end user perspective. And so we're working currently on a care map for breast cancer, and so my challenge to the group was, one of my staff came to me because he's embedded in the cancer center now, and he came to me and said, we've got this care map. And I said, have you tested it with patients? Do patients find it useful? Instead of, before you go to someone to develop the whole thing and print it out, you better ask the patients to see if they're going to use it, because you don't want to spend all this money and not have the patient use it. Initially, what did usability tell us? That initially, when we started this out, the action plans were just text pads, like you could just write in stuff, and so we changed that according to our responses. The initial design was based on what the clinician wanted and not what the patient wanted, and so working with patients, we got that different purview of what they would utilize. The impact of the motivational inquiry approach from a patient-centered perspective was absolutely essential. And so in some action plans, diet and blood pressure, we're utilizing that. Not necessarily so will we be doing it with an education action plan. They weren't so keen on that. I talked about ESAS and use of the telephone as a medium for patient self-referral. We're not going to be doing that. And then looking at ESAS at University Health Network, they're not even going to be doing it now, so it's not applicable. Privacy impact assessment absolutely added to the scope of our project in terms of security and privacy considerations, and has challenged us in terms of retention of records, that kind of information, and how we're going to manage that as an ongoing basis, especially in light of the fact that we do have patients that use a lockbox component of PHIPAA, and that's a challenge in any IT environment in healthcare, but more so when you need to communicate those requirements from patients across different applications where the processes don't exist. Innovation and project management. I did this for Dominic, and then he says he's not going to be here. Don't necessarily work together. So you see my guy with the briefcase, and so one of our biggest challenges that we've had with this particular project was an 18-month project, was the fact that we wanted to be really innovative. We wanted to do many iterations, but you know what? We only had 18 months, and we only had so many dollars. We only had the $2 million. And so that puts a lot of constraints in terms of doing things in an iterative process, and has created some angst, and has really made us lobby for different processes with our investment agency to say, if you want this kind of innovation and creativity to happen and you really want it to work, you need to reconsider how these investments are made and the time frame that is allocated to them. So here's doing it again. Sorry, I forgot to save things up. So really, we're looking at, this is basically what we had designed as a development and testing process. So we had a lot of deliverables associated with the process, and you're looking at between 130 and 275 days. And so try to add in an iterative development cycle in that, very tough to do. Lessons learned, the 3 big C's: clinical practice and engagement in healthcare, absolutely essential, and can help you or cannot help you. Culture, phenomenal. I have seen in our chronic kidney disease, that program has a different culture. And I don't know if it's related to the chronicity of the disease cycle with those patients. Those patients have services for an extended period of time, and cancer is much more prescriptive, although it has a chronic component. But really the engagement of that particular staff group and the patient group in particular has been phenomenal. And week one, we did a soft live November 30th. Week one, we had 20 patients sign up to Portal. And in the cancer environment, it took us 4 months to get 20 patients. So there's a huge difference in how we've engaged clinicians, how we've engaged the renal community by going to their annual general meeting, and how we've created a sense of excitement around this project and supporting patients in self-managing their care. And change management, huge. What can I say? Everybody hates change, but we live it every single day. So really looking at having the appropriate processes and support from senior managers in order to facilitate a process like this. And really, I think the biggest piece for us was the fact that we were able to engage the end user, we were able to engage the clinicians, we were able to have the support of our senior management. We have very, very passionate people on our team, and we like to have fun. And so really translating that into having champions in that environment has been a huge component of the success for renal in particular. We're still working on cancer. We're still working on it. It's going to get there. Our challenges, basically, many times it's a learn-as-you-go environment, both from the technology platform experience as well as the clinical practice experience. And, you know, you're doing everything. You're doing privacy, you're doing security, you're doing education, you're doing marketing. It's constant. And so really it's a learn-as-you-go environment. Organizational readiness, I think when we look back, we reflect. I'm a big person on reflective practice. That's my nursing background. But when you look back, cancer wasn't really ready. We were before their time. Renal was ready. They were engaged before we started. Integration of the application into clinical workflow I talked about. The fact that there are a lack of processes that exist, and sometimes you have to work around that and you have to challenge people in order to get those processes to developed to support the use of such an application. Lack of research in this field. Everybody says, oh, prove it to me, prove it to me. Well, you know what, this is innovation. That's the whole point. You know, we're working on something so we can prove it to you or not prove it to you, but that's a difficult challenge, especially when you're looking for additional fiscal resources. IT constraints, I talked a little bit about platforms in itself, but it doesn't go just to platforms. It looks at, you know, integration with HL7 interfaces, how do things match up, you know, can we get Dawn's laughing, how can we, I mean, it's huge, and you don't really recognize that in the beginning if you don't even know how to open and access database, right? And then fitting into the big healthcare picture, because what we know as healthcare today is not going to be what it is 5 years from now, 10 years from now, 20 years from now, and trying to have a vision in order to make things flexible so that we can adapt IT applications to meet those needs. Successes. Well, perseverance makes many things possible, so we're quite tenacious and we keep going at it. Collaborative relationships with patients. You need to know what the end user wants. You need to do usability. You need to keep asking. Integration of professional staff between organizations. That was a big win with this particular project because we were able to look at the tertiary and the community environments, and it was amazing to see not only the collegial relationship between those providers, but the deliverables that came out of that was fantastic. The engagement of staff in the project phases was, and it has been and continues to be, very, very positive. We're redesigning workflows, and that's what we need to do. We need to make things more effective, more efficient, and more applicable across the continuum of care. Developing partnerships. We've got a lot of different partnerships that we've developed with this project, and has been a huge support for us, not only in terms of things that are happening with this group, but with Hamilton, but also with other organizations that are doing portals, which has been quite valuable. And the project deliverables. So when you always start a project, you think, oh, we've got all this stuff, we've got all these templates. Yeah, I'm just going to take those and I'm going to redo them. Guess what? They don't exist. And you're thinking, okay, you know what? So they didn't exist. I'm going to put a lot of effort into developing these, and now we have them for our organization. And so that's been a real benefit as well. And that's it.
thank you, Claudette. I guess I've got a mic on already. That was a really interesting presentation, and I invite the audience to ask questions. I will be the poor Dominic substitute in terms of facilitating this discussion, so please ask your questions. I just want to note that this is being video recorded, so for those of you that are maybe shy of asking a question or whatnot. So any questions from the audience?
Oh, Don.
Don will ask the hard ones, I know.
I know, he told me he'd do that.
Actually, two questions. One is, was renal ready because you experimented on cancer first? In other words, they had an opportunity to watch it in action. And then the second question is, one of the challenges you didn't put up there is sustainability.
Yes, you're right.
You have an issue of translation, so that, in other words, you don't have those big mouthy words that docs speak and no one can understand. And then keeping it up to date with material that's appropriate, because as we know, if we go on the internet, the material, sometimes we find stuff that's appropriate, but there's no real way of knowing.
Right. So two questions. The first one related to the fact that was renal more engaged? Well, you know, there are people in the renal program that didn't even know what we had done in the cancer world. But part of the whole relationship with renal was saying, you know, we've got this portal. I mean, we hadn't even showed it to some of them. And it was a long time before they actually came to the fact that, yes, we want to do it. It didn't happen overnight. I would say it took almost a year. So we started off, we showed it to different people on their quality council. And then it came time, and those individuals on that quality council were really the drivers of bringing this forward. Yes, we want to do this for our program. So it wasn't really me as a director, it was the staff. And so seeing what they could potentially do to support the engagement of patients. And I think really it's their community environment with their patients that made the difference, honestly. The other comment was about sustainability and bingo, bango, bongo. It's a huge issue. And what we've done in the interim with portal development and the content, because it is a big piece. A couple of things, looking and, you know, exploring the whole idea of potential repositories of information. I think one of the things that we need to, or what we've done with our programs, is to say, you have ownership of this portal, right? The information, the content is supposed to be reflective of what you're doing in practice with your patients. And so really taking the ownership of that and facilitating the correct workflow processes to support the translation into the environment. And so they have different councils. They have practice council, they have quality council, they have education. And so the result of all of those things, all of those processes, really need to be translated, and that's what we're working on. So with renal, we're not at the point, you know, we've had a soft live, we're not fully completed the project, but we've talked about embedding that particular individual as a piece of that particular program to bring that forward. And really those programs are making investments in order to do that.
Going back to the readiness question, the world moved forward too. So
Yeah.
from the time that you did the patient portal for cancer patients and the CKD, the chronic kidney disease portal, many more people have become aware and attuned to using the internet for that sort of information. So maybe that might account for a little bit more acceptance.
I think, you know what, I think I'll say it comes back down to the culture. I can't, you know, it's just been an amazing experience to see the differences in those populations.
I think there's a question.
Claudette, my question concerns measurables, and particularly early in your talk when you were giving assumptions, you were talking about things like the doctor's competency in terms of communicating and educating the patients. And I could see that being rather difficult to measure. You ask a patient what the most valuable thing they learned from that interview was, and it had nothing to do with the message that was being communicated. I know later in your talk you used a lot of numbers, and presumably when people see statistics they perk up and pay attention. But in measuring the discrepancy in those assumptions from what I perceived was common sense, there was a significant discrepancy, I think. And I'm just wondering if you've made any effort or progress in measuring some of those things?
Well, the answer is no, not really. So much of that is dependent on the actual program. And so there is recognition from, a very qualitative point of view that there are issues, and we have language barriers and that kind of thing, and we have issues with competencies. And so one of the projects I know that the Cancer Center in particular is looking at is the whole patient education piece of it and looking at those competencies. So they're in the planning phases of actually doing that project, and part of the outcomes will be the effectiveness of staff members recognizing different learning styles of patients and how they've adapted their practice to support that to engage the patient. So we're not there yet. It's slow. It takes a long time.
Two questions. One is on outcomes again, and I was wondering whether your program has looked at the patient outcomes as a result of this. And it sounds like you're tracking satisfaction, which is great. But how about sort of recovery times or response times? So are you actually tracking those? So
We've started, we've defined now some service level objectives that we're starting to do tracking. So responsiveness in terms of, if there's a concern, we respond within, 48 hours, that kind of stuff. But in terms of length of stay in that, complicated. Like, how can you prove that a patient portal has an effect on length of stay of someone who has colorectal cancer who's coming to emerge, but they have a different variable associated with that admission? Very difficult to do. We've talked about with CKD in particular is future randomized controlled trial, and certainly we're interested in that, but we haven't gotten there yet.
And the second question relates to your investment decisions. So it sounds like the first time around you self-financed the cancer portal, and the second time around Infoway stepped in. So I'm curious what kind of requirements there were as far as, who you had to convince the first time around, the kind of information you had to provide them, what kind of feedback they were requesting as it was ongoing and afterwards. And the difference then between that and what you're now doing with Infoway.
So in the beginning, we had to go to a lot of meetings because it was something new. So in the beginning, we had a lot of support from our then CEO and the CIO, absolutely, and from our board. So what happened was there was a business case that was developed, and part of that was the whole medication piece of it, which really didn't pan out in the long term. But we had to have approval from finance and audit and that sort of thing in order to proceed with the project. Along the way, we've been able to get some resources, and of course the Infoway has been a great support. But operationally, we have very minimal FTEs to support this application. It's really tight, like it's one. It's not a lot of money in order to support it. And that comes from a decision from our senior executive team, and that funding comes through our global budget.
I find it interesting that the Canada Health Infoway funded project is an innovation project, and they were capped at a certain amount of money. I think about $2 million per project, if you got that. So it wasn't assured that you'd get the $2 million, but it was up to $2 million that a particular project could be funded. And they also stipulated that it had to be done, all the work had to be done in 18 months. Why I find this so interesting is that innovation is not necessarily timely. Sometimes it takes time to be innovative. And yet there were these restrictions on the timing of the project. So you're marching along on these days, literally days, you've got to do this and this and this and this and this. Well, that really restricts your innovation, the interaction that you need in order to do the innovation that has to be accomplished. So I've been arguing since day one that I don't really understand this program that stipulates that innovation must be done within this short period of time. I just find it very, very difficult for that to be accomplished, or if you want it to be a successful project. But all the projects are the same. We're engaged in another one with VON Canada, and to develop a similar project. And again, they're running into the same issues of trying to create this innovative program within that short time period. So I guess you do it as best you can. There's a question here.
I have two questions. First being, can you further explain some of the information limitations for staff? You mentioned it in regards to something in regards to the portal, so I'd just like some clarification on that.
Information from staff. Well, healthcare is, as I said, a changing environment, and so information is, you're in information overload, and as a practitioner, you can never be up on all the best information. And translating that, so you have different practitioner groups that are working, right? And so that information doesn't necessarily cross those boundaries, and that's where you get the miscommunication with patients. So it's complicated, and it takes a real effort by the multidisciplinary team to come up with a consistent amount of information or type of information in order to translate to the patient. And I think we've made strides. I mean, certainly in terms of looking at clinical practice, so clinical practice council, education council, quality council, and working within those frameworks in order to streamline what's being given to the patient or communicated to the patient.
And the second question is in regards to the use of message boards on the portal. Mm-hmm. Now, I'm not sure of the current state of the message boards on the portal, but my question focuses on the interaction of patient to clinician and vice versa on these message boards. Does that exist? And if it does, sort of gets into the cultural issue of patient-physician communication via email, and could the message boards be a good starting point towards getting to that?
Well, you need resources to do that, and so no resources. So we do have discussion boards where patients interact with each other. They're not facilitated. Princess Margaret, for example, has Caring Voices, which is a facilitated discussion board with between clinicians and patients. So at our organization, we didn't have the resources to do that. So we developed this discussion board. And it's not used by all patients with different diagnostic types. It's used primarily by patients with breast cancer, patients with melanoma. And so we check it off and on, but basically it's their space.
Okay, so you facilitate, but you do not intervene.
No.
I know this discussion is running over a little bit, but I'd just like to go back to the motivational inquiry that's been included in the CKD portal. Maybe you could just explain the incentive or why you're going about that.
Okay, so I talked initially that we had text pads for writing information down, and we had a lot of dialogue with Dr. Gina Brown at McMaster in terms of chronic disease management and patient goal setting. And what's the motivation for changing behavior? And so the whole motivational piece really blasted out our scope of our project because it added a huge amount of complexity. So essentially, it's taking the motivational inquiry approach, but the patient is documenting those particular parameters around setting a goal. So they identify, this goal is the importance of the goal, how confident I am once they set the goal, what are the barriers that I foresee, who can help me, what are the ways that I could achieve this, and then they submit that goal. And then related to that goal, then they just document different parameters. So if it's in the blood pressure action plan, for example, they monitor their blood pressures and they document that and they put that in. Then we have a progress section, which is a tab 3, and the progress section counts down the days and writes down, here are the things. So it gives you a graph in terms of your diastolic and systolic pressure and how you're achieving that. And when the goal date arrives, then there's a message to say your goal date has ended or whatever. And do you feel that you've accomplished this goal or not accomplished that goal? And then it's stored. And then we provide educational content to do that. So we've done that with both blood pressure and diet, two of the key levers associated with managing chronic kidney disease.
One of the things that we've had a lot of discussions about in terms of motivation is that a number of patients, and indeed in the other project that we're working on with VO in Canada, the potential users of the portal could be depressed. And then how do you get a person that is experiencing depression to actually use a technology that they may not want to even engage in because of the sheer fact that they are depressed? So it's a very tricky sort of situation, and that's where the motivation aspect becomes very, very crucial in terms of trying to engage people to use something that you desperately want them to use. I don't know if you want to comment on that.
Well, I think the other important piece is that we really don't have a clear understanding of how many patients are actually depressed. And we don't really understand the characteristics of users of patient portals. And so part of our evaluation methodology associated with the chronic kidney disease portal development is looking at the characteristics of users and non-users, and then doing some evaluation in terms of survey completion and being interviewed by a researcher at the same time. So that's part of that. And I think we'll get some valuable information. Some of it will be generalizable and some of it will not.
Are there any other questions? Well, thank you, Claudette. I really enjoyed your presentation. So thank you for coming and speaking to us today. And we'll see you back here in January. Have a good holiday season. Thanks for coming today.